Okay, hello guys. So now I'll be talking about the cystic fibrosis of pancreas. So cystic fibrosis of pancreas basically it's an autosomal recessive disorder. Okay, let me just zoom in for you. Yeah, so it's an autosomal recessive disorder. The risk factor for this is that cystic fibrosis usually runs in the family, or the person who's affected by this is of a European descent, typically Northern Europe or Eastern Europe. Now, what's happening over here is you have something known as a CFTR gene. CFTR gene is nothing but cystic fibrosis transmembrane regulator gene. This is a channel, it basically codes for a protein channel. And this protein channel, there's chloride ions that gets pumped through this channel into the ducts, which contain the secretion. And when this chloride is usually pumped into the duct, what can happen is the chloride will draw water as well. Therefore, the secretions now also have water, making them less viscous. So when there is a problem with the CFTR gene, more specifically, there is a deletion, okay, delta deletion. F stands for phenylalanine, F phenyl, and 508 is 508th amino acid. So when there's a deletion of the 508th amino acid, which is phenylalanine, in the gene that codes for CFTR, there's going to be a problem with this, okay? And when there's a mutation of that, the CFTR protein gets misfolded and they cannot migrate from the ER to the cell membrane. So if they cannot go to the cell membrane, then there'll be lack of these channels, and therefore the secretions become thick because now you don't have chloride moving out of these cells into the ducts. Now, the mutation of the CFTR gene usually presents with a classic triad of problems, which is increased chloride in sweat, um, there's chronic sinopulmonary disease, there's pancreatic insufficiency. So I'll speak more about these in a moment. Now, when you're answering this question, first you explain the pathogenesis, okay, of cystic fibrosis, and now you go for the timeline of problems. So divide the problems with cystic fibrosis into this following timeline: newborn situation, early childhood, late childhood, and adulthood. Starting with the newborn, the most prominent problem is that there'll be meconium, which becomes thick and it gets stuck in the intestines. So when it gets stuck in the intestine, it causes meconium ileus. And for this, there's an emergency. It's an emergency, so they have to perform surgery. When you go to early childhood, this is where the pancreatic insufficiency usually occurs. So the pancreatic secretions are now thick. They will block the duct in the pancreas, and this results in two main problems. One is that the digestive enzymes won't be able to make it all the way to small intestine because the ducts are now blocked. And because of this, the intestine now doesn't have any pancreatic enzymes. Therefore, proteins and fats are not absorbed and they're not digested properly. This will result in steatorrhea and also results in poor weight gain and failure to thrive because of lack of absorption of nutrients. The second problem is that there'll be backup flow of the enzymes. So if there's a blockage at the exit, then there'll be a backflow of the enzymes. So this can cause two problems. Number one is after it degrades the duct and the parenchyma of the pancreas, it can cause endocrine dysfunction, for example, insulin-dependent diabetes, where now over here the enzymes are going to destroy the pancreas. Okay, so there's going to be insulin-dependent diabetes. And the second is inflammation, just regular inflammation. This inflammation can go widespread and can cause acute and chronic pancreatitis. These will then also be combined with gallstones, and eventually cystic fibrosis will develop. So you have cysts and fibrosis within the pancreas. So that's what's going to happen. Now, coming to late childhood, so you're going to have all the problems of early childhood plus lung problems. So what are the problems? Number one is the thick mucus in the lungs will cause a blockage, which will then cause bacterial colonization. This will obviously cause cough, fever, pneumonia, right? And when this becomes, very much prevalent, so there'll be a lot of symptoms. Plus, when there's decreased lung function and also visible changes in the X-ray of the chest, it's called as a CF exacerbation. Now, after cystic fibrosis exacerbation, when there is chronic presence of the bacteria, there's chronic bacterial infection, This can result in bronchiectasis because the bacterial colonization and also the presence of mucus will eventually degrade the walls of the alveoli and can cause bronchiectasis. At the same time, there'll also be degradation of the vessels, which will then cause hemoptysis. In severe situations, it can lead to respiratory failure, where there'll be severe hypoxemia and hypoxia. Other problems, apart from the lung, is that there'll be infertility in men, maybe mostly due to lack of vas deferens. There's also the formation of nasal polyps, and there is ABP aspergillosis. This is acute bronchopulmonary aspergillosis, where there'll be invasive aspergillosis infections, or at least an increased risk of these infections. Then there's also dehydration that can occur. There is vitamin A, D, E, and K deficiencies because these are fat-soluble vitamins. Then there's also nail clubbing because of uh, compromise of the lungs. Therefore, there'll be hypoxia, and also there can be anemia. So that's the first page. Okay. Now let's go for the second page. So let's look at the signs and symptoms. So you have pancreatic manifestations, pulmonary, and others. In others, again, as I mentioned, clubbing of fingers, toes, infertility in men, meconium in newborns, dehydration, and there can be hypochloremic alkalosis where there'll be less chlorine within the body. And this is because there's excess loss of chloride to sweat. So there's high chloride content in the sweat, and there'll be low chloride content within the body. There'll also be rectal prolapse, heat exhaustion because of dehydration, and cirrhosis as well, because cystic fibrosis can also cause problems with liver. Coming to pancreatic manifestations, typical signs of pancreatitis, they can be Cullen's sign, Gray Turner's sign. They can be nausea, vomiting, fever, increased heart rate. Uh, yeah, and then there can be formation of gallstones. You can identify this with ultrasound. And again, typical symptoms, usually after eating, there can be like a lot of uneasiness and discomfort. Then addict deficiency with steatorrhea and weight loss and failure to thrive. This I've already mentioned before. Then you've got pulmonary problems, which is typically dyspnea, chronic cough, often productive. And also there's an increase in the anterior posterior chest diameter. There's crackles because of the deposition of mucus, usually in the basilar part. Um, However, there's generalized hyperresonance, especially when you're doing percussion. Also, there's expiratory wheeze. Then there can be anemia and low oxygen saturation because of airway compromise. I mean, lung compromise. There can also be digital clubbing because of low oxygen saturation and hypoxia. There can be pneumothorax, especially if the mucus and the bacterial colonization eats away into the periphery of the lungs, and then there can also be escaping of the air from the alveoli into the pleural cavity because of that. Typical signs and symptoms: sharp pain, can radiate sometimes. Um, yeah, and then there can also be an asymmetrical rise of the chest while breathing. There's nasal polyps, sinusitis. This is the chronic nasopulmonary syndrome, hemoptysis, then ABP, allergic bronchopulmonary aspergillosis, where there's invasive fungal disease, and of course, pneumonia and chronic bacterial infections. So the most common organisms in children are Haemophilus influenzae. Otherwise, it's Staphylococcus aureus and Pseudomonas aeruginosa. Ultimately, they can lead to respiratory failure. Now, coming to diagnosis, prenatally, we perform ultrasound. We can detect meconium peritonitis and hyperechogenic bowel. This is usually due to congestion within the bowel. Then we can perform chest X-rays, CT scans, which is diagnostic methods. Usually you can see hyperinflation, flattened diaphragm because of hyperinflation. And in CT scan, you can see all the bronchial secretions and bronchiectasis. Bronchiectasis, you can see it very well. Then pulmonary tests, you can see a decreased forced expiratory volume, increased residual volume because air can enter but they cannot escape, and even the ability of the person or the patient to expire forcefully will decrease. Total lung capacity decreases because of the deposition of mucus, and in essence, vital capacity also decreases. Now, if you want to look at the lab testing, you can do genetic testing, you can identify CFTR mutations. You can also do a sweat chloride test where you administer pilocarpine. Pilocarpine will cause sweat secretion, like increased sweat. And you can collect the sweat and you can identify how much chloride content is present. Um, that's that. Now you're going for treatment. So typically antibiotics to take care of infections, bronchodilators to help you breathe, anti-inflammatories such as glucocorticoids and other steroids to suppress the inflammation. And you can also take you can also inhale hypertonic saline to clear out the secretions because they act as mucolytics. Vaccines such as anti-influenza and anti-pneumococcal, surgery, lung transplant, you can also provide some additional support, airway support, ventilatory support, provide oxygen support. You can also address the complications that arise with cystic fibrosis, and you can provide chest physiotherapy in order to help make breathing more easy. Other treatments is typically nutritional support and provision of mucolytics. So, just a picture over here. Cystic fibrosis usually not only affects the pancreas, but also the liver and the lungs, also the intestines. So if you look at the normal airway of the lungs, you see it's pretty clear. Whereas in cystic fibrosis, there is bacterial infection along with blockage of the airway due to the presence of sticky mucus because chloride is now being pumped into the mucus for water to be drawn along with it. There can also be blood in the case of degradation of the vessels. So here you can see this is an example of a pancreas. Okay, it says it's a 32-year-old CF patient. So there's complete replacement of the parenchyma by fat. There's pancreatic lipomatosis that can occur as a severe situation. So macroscopically, you can see extensive fibrosis. There can be cystic spaces. There can be complete replacement of pancreas by fat. Um, yeah, and usually on this CFTR gene problem occurs on chromosome 7. Here you can see the microscopic situation. These are at an advanced stage. Here you can see the parenchyma is just filled with fatty deposition, and only small areas or islets of the pancreas are seen. And there can be some there can be some fibrosis as well over here. Here's another example. You can see cysts, you can see necrosis, hemorrhage, blood is filled over here. You can see fatty uh, replacement. Here you can see more cysts, although I think this is not necessary for cystic fibrosis specifically. So pancreatic lipomatosis, you can see over here. So in this situation, what's happening is you can see the head of the pancreas and it's filled. There's a cyst that's formed over here. Okay, and you can also see sub-centimeter cystic focus in the expected region of the pancreatic tail. That is over here. Okay, so this is the tail, pancreatic tail focus. And also there's complete replacement of the pancreatic parenchyma by fat in this area. Over here, there's a cyst that covers it. So that's pretty much it for cystic fibrosis. So yep. If you have any more questions, please feel to message me. Um, Thank you. Take care and all the best for your exams.